Hello, class. Welcome to Flourish Nursing Academy. I am Tutor Godwin. We will be looking at diabetes mellitus. Diabetes is a condition that results from a lack of the hormone insulin in a person's blood, or when the body has a problem using the insulin it produces, insulin resistance. Also, diabetes mellitus is a group of metabolic disorders characterized by elevated levels of blood glucose, hyperglycemia, resulting from defects in insulin production and secretion, decreased cellular response to insulin, or both. 2. Major types. What causes the problem? Type 1, T1DM, autoimmune destruction of pancreatic beta cells, little or no insulin. Often presents in children, young adults, risk of diabetic ketoacidosis, DKA. Type 2, T2DM, insulin resistance, muscle, fat, liver, plus progressive beta cell dysfunction, relative insulin deficiency. Strongly associated with obesity, inactivity, and chronic inflammation. More gradual onset. May present with hyperosmolar hyperglycemic state, HHS, in crises. Other, gestational diabetes, monogenic forms, secondary, pancreatic disease, pancreatic diseases, pancreatitis, carcinoma, endocrine disorders, Cushing's syndrome, acromegaly, drugs, steroids, thiazides, phenytoin, gestational diabetes, mellitus, hyperglycemia, first recognized during pregnancy. Secondary diabetes, diabetes caused by other conditions, such as risk factors, obesity race, hypertension, physical activity, familial history, pregnancy, pathophysiology of diabetes, mellitus. Without enough insulin or with insulin resistance, cells cannot take up glucose, high blood glucose, hyperglycemia. Kidneys filter excess glucose, osmotic diuresis, dehydration, loss of electrolytes. Fat is broken down for energy, free fatty acids, ketone production, T1, DKA. In T2, some insulin often prevents large ketone formation, but extreme hyperglycemia causes severe dehydration and hyperosmolarity, HHS. Long-term hyperglycemia damages small and large blood vessels, nerves, and tissues via advanced glycation end products, AGEs, oxidative stress, abnormal metabolic pathways, polyol pathway, PKC activation, chronic inflammation, retinopathy, nephropathy, neuropathy, atherosclerosis. Clinical manifestations: hyperglycemia, polyuria, polydipsia, polyphagia, fatigue, blurred vision, recurrent infections, slow wound healing. DKA, nausea, vomiting, abdominal pain, small respirations, fruity breath, dehydration, tachycardia, hypotension, altered mental status. HHS, profound dehydration, extreme hyperglycemia, confusion to coma, absent ketones or only small amounts. Hypoglycemia, important nursing emergency. Sweating, pallor, tremor, hunger, tachycardia, anxiety, confusion, seizures, loss of consciousness. Diagnostic tests: fasting plasma glucose, diabetes, 126 mg/dL on 2 occasions, random plasma glucose, diabetes, 200 mg/dL with symptoms, oral glucose tolerance test, 2-hour, diabetes, 200 mg/dL, hemoglobin, A1C, diabetes, 6.5%, treatment target commonly 7%, individualized, acute severe states, DKA, hyperglycemia, often 250 mg/dL, ketonemia, ketonuria, metabolic acidosis, low pH, low HCO3, HHS, very high glucose, often 600 mg/dL, marked hyperosmolarity, little no ketones. Type 1, types commonly used, onset, at peak, duration, approximate. Rapid acting, lispro, aspart, glulisine. Onset, 10 to 20 min, peak 1 to 2 HR, duration 3-5 HR, often given with meals. Short-acting, regular. Onset 30-60 min, peak 2 to 4 HR, duration 6 to 8 HR, often IV and DKA HHS. Intermediate, NPH. Onset 1-2 HR, peak 4-12 HR, duration 12-18 HAR. Long-acting, Glargine, Detamir, Degludec. Onset 1 to 2 HR, minimal peak, duration 24 plus HR, background insulin. Nursing points. Check correct insulin, dose, route, timing relative to meals. Use a correct syringe pen device. Rotate injection sites to avoid lipohypertrophy. No facility protocols for insulin reconciliation and sliding scales. Note: sliding scale alone is not ideal long-term. Monitor for hypoglycemia after insulin and after changes in nutrition or activity. Type 2, oral hypoglycemic agents. Inadequate control of hyperglycemia by the diet and exercise interventions suggests the need for a good glucose-lowering agent. Oral hypoglycemic agents are useful only in the chronic management of patients with type 2 DM. The most commonly used are 1. Sulfonylureas, 2. Biguanides, 3. Alpha-glucosidase inhibitors, 4. Non-sulfonylurea insulin stimulators, glinides, 5. Thiazolidinediones, glidazones, 6. Dipeptidopeptidase IV, DPPR inhibitors, 7. Glucagon-like peptide 1, GLP-1 receptor agonist, 8. Analog of amylin, pramlintide. Diet: fill 1/4 with a lean protein. Fill half with non-starchy vegetables. Exercise before. Include a 5-minute warm-up, check blood sugar. After, include a 5-minute cool down. Check blood sugar. Nursing priorities in acute care. Triage and initial actions. Always check capillary blood glucose for symptomatic patients or altered mental status. For hypoglycemia, conscious. Follow Rule of 15. Give 15 gr fast-acting carbohydrate, juice, glucose gel, wait 15 min, recheck. Repeat if needed. Then provide a longer-acting carbohydrate protein snack if the next meal is not soon. For severe hypoglycemia, unconscious or unable to swallow, follow facility protocol, IV dextrose, D50W if IV access, or IMSC glucagon if no IV. For suspected DKA HHS, promptly notify the provider or rapid response. Monitor vitals, capillary blood glucose, urine, serum ketones, serum electrolytes, blood gas, and mental status. Establish IV access, expect IV fluids, insulin infusion, and electrolyte replacement, potassium per orders. Remember potassium, K. Serum potassium may be high initially, but total body K is low. Insulin therapy shifts K into cells. Monitor and replace as ordered. Monitoring and prevention of chronic complications. Nursing role. Foot care. Daily inspection. Proper footwear. Treat minor injuries promptly. Refer to podiatry for neuropathy, vascular disease. Blood pressure and lipids. Control reduces cardiovascular and renal risks. Reinforce medication adherence. Eye care. Annual dilated eye exam. Teach patients to report visual changes. Renal function. Monitor urine albumin, microalbuminuria, serum creatinine. Teach avoiding nephrotoxic agents. Neuropathy care. Screen for decreased sensation. Monofilament test. Patient teaching to avoid burns injuries. Vaccinations. Follow guidelines, influenza, pneumococcal hepatitis B as indicated. Patient education topics nurses should cover. Blood glucose self-monitoring. How, when, target ranges, when to call provider. Medication adherence, timing, side effects, storage, insulin refrigeration until opened, injection technique. Sick day rules. Continue insulin, monitor glucose and ketones. More frequently, maintain hydration when to seek care. Diet and exercise basics, carbohydrate consistency, timing of meals with insulin, and gradual increase in activity. Hypoglycemia prevention and treatment, recognizing symptoms, carrying fast-acting carbs, and medical alert identification. Foot care and infection prevention. Quick reference of danger signs that need urgent action, recurrent or severe hypoglycemia, seizure, or loss of consciousness. Signs of DKA, vomiting, abdominal pain, small respirations, fruity breath, progressive lethargy. Signs of HHS, extreme hyperglycemia, severe dehydration, confusion, coma. New focal neurologic signs or chest pain, consider stroke, MI, and notify immediately. Complications of diabetes, mellitus, acute diabetic, ketoacidosis, hyperglycemic hyperosmolar, state, diabetic, foot, ulcer, infection, chronic, microvascular, retinopathy, nephropathy, neuropathy, macrovascular, accelerated. Arteriosclerosis, myocardial infarction, stroke prevention. For obese patients, especially those with type 2 diabetes, weight loss is the key to treatment and the major preventive factor, the development of diabetes.